Right, just so that everyone know, we will record this session and we will post it in our YouTube. We have platform X, Instagram, and also YouTube. As on the display, there's also our Gmail if there's any improvement in suggestions. And kindly scan the QR code for attendance. Assalamualaikum and a very good afternoon to everyone. On behalf of the organizing committee, I am pleased to welcome you to today's mycology webinar titled The Candid Truth When Guidelines Meet Practice. Thank you for taking time out of your busy schedule to join us. It is encouraging to see participations from the clinical sections, from the laboratory, and also esteemed professors from the universities. Highlighting the truly multidisciplinary nature of managing fungal infections. Today's sessions aims to explore the honest intersection between evidence and practice, what works well, where challenges arise, and how clinical judgments plays a critical role in managing candidiasis. We are honored to have two distinguished speakers who bring complementary perspectives, one from frontline infectious disease practice and the other from internationally recognized expertise in clinical microbiology and fungal infections. Together, they will offer both local relevance and global insight. I will first introduce both speakers before I give the floor to them. So our first speaker is Dr. Nur Aisha binti Abdul Wahid, an infectious disease physician from Hospital Sungai Buloh. She has extensive experience managing complex infections in tertiary care settings and is actively involved in antimicrobial stewardship, infectious control, and clinical research. Today, she will share practical insights on managing candidiasis in real-world hospital practice. Our second speaker is Professor Deborah Marriott, Senior Specialist in Clinical Microbiology and Infectious Disease in St. Vincent Hospital, Sydney, and a conjoint professor at University of New South Wales. She is internationally recognized for her expertise in fungal infections, antifungal pharmacology, and therapeutic drug monitoring. Her experience across different healthcare systems offer valuable perspective on adapting guidelines safely and effectively. Without further delay, let us begin. I will first invite Dr. Nur Aisha to start the session, followed by Professor Deborah Marriott. We will then open the floor for questions and discussion. Kindly post your queries in the Q&A box. The second welcome, and I hope today's will be both insightful and clinically relevant. Dr. Aisha, the floor is yours.
Yeah, hi. So I'll start with sharing my screen here. Right, okay. The screen is on, yeah? All right. So, can you see my screen, Dr. Ain?
Yes, we can see.
Right, okay. So, Assalamualaikum and hi everyone. Thank you to all those joining us out there. So, I'll start with a case-based discussion on our topic today, titled Candidemia. Oops. Oh, sorry. Go on, yeah. Okay, All right. Okay, sorry. Um, so yeah. So this is our case. We had a 60-year-old lady with type 2 diabetes and hypertension. She
Aisha, we
had
are
a
not seeing your slides.
yeah,
We only see your face. Yeah, it works this now.
Yeah, it was on just now.
sorry. I'm sorry. Okay, how about now? I'm sorry.
Hold on, started. Okay, yes, we can see now. If you can put it on presentation mode.
So, right, now the screen is moving.
Yes.
Okay, sure. All right. Okay, apologies for that. So, okay, this is the case. So, we had a 60-year-old lady with type 2 diabetes and hypertension, and she had a history of childhood spinal trauma, of which she was confined to the wheelchair because of her paraplegia. So, her she was admitted early in September 2025, and her main admission problem was actually for an infected gluteal sore at the right hip area. So because of this gluteal sore, she had multiple debridements, including a hip autosomal washout. Part of the treatment, she required antibiotics, but somehow in October 2025, her condition deteriorated because of pneumonia and she had to be intubated. Of course, antibiotics was continued and this was changed to tazocine before it was escalated further to meropenem for her further deterioration. Now, as with all critical care patients, she required dialysis at some point of the stay. She also had an episode of CRBSI, of which she grew ESBL, Klebsiella pneumonia, and this was treated. So moving forward, her fungal story started in December 2025, when it was found that her blood culture centrally and briefly grew these cells. So the ward team promptly gave her fluconazole. However, a few days later, we found out that the yeast cell was actually Candida tropicalis, which showed resistance to fluconazole. So instead of fluconazole, this was stopped and hence this was changed to anidulafangin. Since the source of the infection was likely from the central line, so this was recited and subsequent cultures were done to document clearance. A referral to the ophthalmology team was also done, and this was the finding as shown here. So as this arrow points, so as you can see the red arrow here, so this describes the presence of the well-circumscribed round whitish lesion, which with her diagnosis of candidemia, her diagnosis then was revised to candidemia with endogenous endophthalmitis. So moving forward, antifungal was stopped from anidulafangin and this was changed to amphotericin B and flucytosine. So as the case illustrates, okay, candida infection is a serious infection. In fact, it is one of the major contributors of nosocomial infection with a mortality rate reported up to 45%. It is quite common, and in the Europe and the US, they found out that about 85% of all fungal infections are actually caused by Candida. And to complicate things further, treatment can be quite challenging because we are seeing a rise of Candida resistance to azoles, as illustrated in our case. The other thing about antifungal therapy is, of which it may not be apparent to us clinicians in government hospitals, is that antifungal therapy is actually among the costliest drugs in healthcare. And it has been estimated that for one patient treatment, it may cost you up to 130,000 US dollars. So what about the Candida burden in Malaysia? Unfortunately, there have not been too many studies on Candida in Malaysia, but there was a disc review paper done in 2020, which showed that, which looked at the different positive isolates, lab isolates of Candida. And we still have the predominant Candida albicans in most of our species, and it was contributed mainly from the high vaginal swab sample, followed by respiratory, and so on and so forth. That paper also looked at the antifungal susceptibility pattern, and our Candida isolates still retain more than 80% susceptibility to azole. So as in our case, we have to question ourselves who would get Candida infection? Because as we know, Candida itself is actually part of the normal human microbiota. So for example, you can actually easily isolate them from the GI tract, the vaginal tract. So the concept of it is a patient would be predisposed to infection if they already have Candida colonization. So in our case, which I didn't describe in detail, this patient actually had previous colonization in the form of a positive urine culture for Candida. Okay, and the other thing is, of course, being exposed to broad spectrum antibiotic due to dysbiosis of the normal human flora. The other thing is her risk is, of course, when she had a break in the skin and body barrier in the means of multiple central catheters insertion, procedures done, operations, which further caused hematogenous spread before forming an infective profile. So as mentioned, so these are some of the predisposing risk factors for a person to get Candida, and this can be broadly categorized into these four categories. Most commonly is, of course, our drugs which we give patients, especially our antibiotics, steroids, okay? Patients' underlying comorbidities, especially those who have undergone transplants, dialysis, okay? Remember that the longer a patient stays in hospital, then they are at higher risk of having fungal infection, especially those who have had a longer stay in the ICU, who's required mechanical ventilation, as in our patient. There are also some genetic conditions that are implicated in fungal infections. So some of it are described in this box here. So as we can see in our case, Candida infection is quite an insidious disease because as it goes and spreads into the bloodstream, it can affect any parts of the organ in the body which it has an interest in. So as our patient, she had endophthalmitis, but remember that Candida can also cause endocarditis, abdominal abscesses, and even bone and joint infection. Okay, so that's why it's important that once you have candidemia, you have to look hard for any deep-seated abscesses or infective profile. Because remember that candidemia itself is actually part of the spectrum of the disease called invasive candidiasis. And to make matters more challenging, studies have found that only about 40% of patients have positive blood cultures in invasive candidiasis. Around 30% of them may only have deep-seated abscesses without the presence of a positive candidemia, and about 20% only may have both candidemia and a deep-seated abscesses. So that is why it is highly important. One, definitely you would have to have a high clinical suspicion of invasive candidiasis. You would also, it is highly recommended as from this Global 2025 guidelines, you would want to get a detailed patient history, a thorough physical examination, okay, followed by imaging of procedures to further aid in diagnosis of candidiasis. So as our patient, we saw that her endophthalmitis was seen through was from the fundoscopy examination. If you suspect an abdominal organ abdominal abscesses, then it would be wise to proceed with abdominal imaging or an echo if you think of an IE. So although I mentioned that only about 40% of our patients with invasive candidiasis have a positive blood culture, cultures are still important and it is still the gold standard for our diagnosis. So what it means is you have to send blood cultures, okay? And if the patient do have some drainable abscesses, do send the samples for microscopy or HPE. Now, the reason that some cultures may be negative is because of lower concentrations of Candida in the blood, or your patient may be in the spectrum of invasive candidiasis with abscesses only without the positive candidemia. It may also be negative for those patients who have a previous exposure to antifungal. For example, those patients who had prophylactic antifungal use. So how do you want to increase the yield? Unfortunately, which your patients and your junior doctors would hate you is, of course, you have to draw more blood. And in fact, it is recommended you send up to 60 cc of blood in different sets of cultures. Do talk to your microbiology lab for the use of specialized bottle, or what we call it the micro F culture bottle here in Malaysia, to improve the positivity rate. The other thing is you would also sometimes need to rely on diagnostic support such as imaging and non-culture based assays, which I will talk about briefly in the next few slides. So non-culture based diagnostic assays. I think all of us would be familiar with fungal PCR and the PISA-D group test. There are some other tests done, such as the T2 Candida panel, but mostly reserved for research setting, I believe. Basically, what they are tests that target the fungal cell wall properties, and the beauty of it is it has a faster turnaround time. For example, the T2 Candida panel was reported to have a turnaround time of about 5 hours only. But the use is, of course, limited by the cost and the availability in some hospital settings. So let's say if you do have the array of all the tests available in your hospital, which one do you choose, right? So this table here shows the different, the previous studies which have examined the performance of these non-culture tests among different patient populations. So mainly has compared between the use in invasive abdominal candidiasis versus high-risk ICU patients. And as you can see here, the sensitivity and specificity has a wide range. So you can go as low as 33% for the specificity and then nearly to 100%. So how does this translate in clinical practice? I believe that the negative predictive value may be more of benefit. So as this table shows, so looking across different patient populations from a lower risk to a higher risk of patients. So as you can see here, all these three tests, so they're using these three tests as comparison, have a negative predictive value of nearly 100%. So basically what it means, it roughly translates to if you have a patient with a negative fungal PCR, then your diagnosis of invasive candidiasis may probably be lower down the rank. But of course, the question of whether to continue or to stop is a whole lot debate on its own, right? Okay, so moving on, we'll talk a bit about choosing antifungal. So of course, these are the questions that I hope you would want to question yourself on. So definitely, which one would you choose? We have a few varieties of different antifungals here in Malaysia. When do you start and how long to give and how long, when to stop? So to aid us, this simple diagram shows the spectrum of indication of antifungal therapy. So as we go through the my right to the left side, so it's quite straightforward to start antifungal when you have a positive culture from a sterile site. Then it's no-brainer to start antifungal straight away. On the other side of the spectrum is you have these relatively well patients. However, they are at high risk because of their underlying medical conditions, such as those who have had a hematological transplant, stem cell transplant, or solid organ transplant. They are at higher risk of having future fungal infection, hence the idea of the concept of prophylactic antifungal for them. So in between these two spectrums, you have those patients who do not have a positive culture. They do not fall into the conventional high-risk patients, but they are high risk in their current settings. For example, those patients who are in ICU in septic shock, or a patient who has had a recent surgery and complicated with anastomotic leak, then you may consider antifungal therapy as an empirical treatment. The other thing is when talking about antifungal stewardship, it is actually recommended to have an ID or clinical microbiology consultation. Mainly, one thing is ID physicians do love our referrals, but on a serious note, it's found that a referral or consultation is shown to reduce the 30-day to 90-day mortality rate. Okay? So what do you want to start with? So as per the IDSC and the global guideline, the latest one, it's recommended for IV echinocandin as the first-line therapy. Okay. What about the duration? This would also depend on multiple factors, especially your source control. So for example, if you have a non-drainable abscess, then it may be prudent to continue your antifungal for an extended period of time with further reassessment. Of course, your duration will also depend on your type of organ involved. So for example, as in our patient, she has a confirmed endophthalmitis. And as per this guideline recommendation, the duration of the treatment would range between 4 to 6 weeks. Now, do not forget about amphotericin B, although it is notorious for its toxicity and side effects. But For our patient's case, the reason that she was changed to an amphotericin B is because of the diagnosis of endophthalmitis. And it is found that echinocandin's role in ocular infection is controversial because of the concentration of it in the vitreous tissue may be lower than the other antifungal. Another consideration of using amphotericin B and amphotericin B plus minus 2 cytosine could be if you have a suspected Candida CNS infection. Right. So moving forward, I would like to really stress on this, and as per recommendation, it is highly important that you would want to remove your central line as early as possible. Because as we know, central lines is a common culprit for nosocomial infection. But then the next question would come about when would be your best time to reinsert a new line? Because it's found that biofilms can still adhere to new catheters. I don't think there is really a guideline about this. However, there was this paper done by Kobayashi, which showed that patients who had a Candida-related catheter infection would have a higher risk of recurrence if the new catheter was inserted within the 3 days of removal. So the concept is we would try to get a longer catheter-free period before considering a new line, but this may be limited by our patient factors or current clinical indication. Right. Okay, so I'm coming to the end of my talk. So overall view is candidemia is actually a serious infection, more so because of the high mortality rate. Okay. It is highly recommended to use your clinical judgment, have a high suspicion of invasive candidiasis, okay, and pair it with other diagnostic aids such as your culture, imaging, and you may want to use the aid of non-culture-based assays to help you diagnose invasive candidiasis. Because of the rise of azole and probably echinocandin-resistant candida, this may prove a challenge in our treatment of candida in the future. So for further references, you may all refer to this latest guideline, the global guideline for diagnosis, which was released in 2024. Right. Thank you very much.
Thank you very much, Dr. Aisha. So now, while waiting for Prof. Deborah Marriott to set up, I would like to remind everyone to fill the attendance, which is in the link in the chat box. And also, if there's any question, please hold it and put it in the Q&A column. I will read the questions at the end of the session. Now, without further ado, shall we call Prof. Deborah?
Thank you very much. Can you see my screen?
Yes, I can. Yes, we all can.
Excellent. Thank you very much. Thank you for your lovely introduction before. I'm sorry I'm not with you in person in Malaysia, which is probably the country I would live in if I didn't live in Australia. I spent many, many visits there and really love Malaysia and the Malaysian people. So thank you for the invitation to join with you today. Dr. Aisha set the scene very nicely for my talk, and her final slide showed the Candida treatment guidelines, which is what I'm going to talk about today, the good, the bad, and the ugly. So just a reminder that the World Health Organization has recently actually developed a priority list for fungal infections. And interestingly, given that people think that yeast are really not that important, when you look at this list, Candida auris, Candida albicans, Nacosomyces or Candida glabrata, and we'll come to the renaming in a moment, Candida tropicalis, which is extremely important in the setting of Southeast Asia particularly, Candida parasilosis, and Candida orpicia krugievetsii or Candida krusei. So you can see that in the WHO fungal priority list, Candida actually make up 6 of the top priority of fungal organisms. And this is based on the clinical need, on the presence of antifungal resistance, the access to diagnostics, the incidence and the complications and sequelae. So Candida are important organisms. Now, if I'm just going to be talking about candidemia, this in fact could be a very short lecture. This graph or this pie chart was from the second of the Australian candidemia studies, which we published a few years ago. And in this study, you can see that, for example, Candida albicans is nearly half of the isolates. Candida glabrata, Candida parasilosis groups are also important. But since that time, many of the Candida species have actually been renamed. And if we look at what's now called Candida, there is actually very little left. So we've lost all of the glabrata group. We've lost that group. We've lost the parasilosis group. Most recently, the Candida parasilosis have been renamed as Pichia parasilosis. So now that group is also gone. So the only Candidas left really now are Tropicalis, Dubliniensis, and albicans. But for the sake of the discussion, I will talk about all of the previous Candida species as being part of Candidemia. But just a reminder that they have been changed, and clinicians hate these changes. As recently as today on our intensive care round, one of the clinicians said, "Why do you keep changing these names? It just confuses us all terribly." Okay, now when we're treating Candida, as we've heard, we do have good drugs, but there is still a very significant mortality. So a retrospective study from Germany showed a 28-day mortality rate of close to 50% and a 180-day mortality rate of nearly 60% in critically ill patients. A multi-center study from Brazil showed an overall 60% mortality in ICU patients. A large Italian study showed an early mortality rate of 19% and a late mortality rate of 41%. We did a nationwide study which showed a crude in-hospital mortality of 56% and a median time from candidemia to death of 7 days. And there was a large French study from a variety, 24 tertiary care centres. They showed that species-specific mortality differences were observed, with higher mortality rates for certain species such as Candida glabrata and Candida tropicalis compared with Candida albicans. And overall, there's been an increase over time of the non-albicans species, and with that, an increased mortality. So why do we want guidelines? I actually pulled this slide directly from a lecture I gave in 2011 in Malaysia, actually, and didn't change the font or the background to show that how much things have changed. So no longer do I use that font and no longer do I use that background, but the contents of the slide is still relevant. So guidelines provide evidence-based recommendations to guide the use of antifungal drugs in both prophylaxis and treatment. They establish categories of patients with hopefully homogeneous characteristics and suggest optimal diagnostic and therapeutic options. They aim to facilitate day-to-day patient management, improve medical therapy, and reduce the variability of clinical practice. And they're useful in changing landscapes of antifungal agents, clinical trials with new approaches to therapy, and as has already been mentioned, cost containment. So what about the Candidemia guidelines? So they were first published in 2000 by the Infectious Diseases Society of America. They were updated by the same group in 2004 and 2009 to include new agents and research. And in 2012, the first ExMID or European guideline was published covering mucosal and invasive candidiasis. In 2016, there was an additional ExMID guideline focusing on the management of candidiasis in adults, particularly non-neutropenic patients. And also in 2016, IDSA updated their candidiasis guidelines. And I love the editorial from this because it's very frank. So it is important to realise that guidelines cannot always account for individual variation among patients. They are not intended to supplant physician judgment with respect to particular patients or special clinical situations. IDSA considers adherence to guidelines to be voluntary, with the ultimate determination regarding their application to be made by the physician in the light of each patient's individual circumstances. So guidelines are that, guidelines, and not necessarily to be followed for every patient. So let's look at the most recent guidelines. So this was 13 pages, which has already just been referred to by Dr. Aisha, published in Lancet Infectious Diseases last year. And this was a cooperative between the Europeans and the Americans on this occasion. And the highlights of these guidelines were echinocandins were retained as first-line therapy. Some of the newer antifungal drugs that are becoming available were incorporated. Earlier step down in stable patients to oral therapy should be considered. Source control is imperative and should be done promptly. A more vigilant approach is needed due to the rise of drug-resistant Candida species, such as Candida auris, with a stronger public health component, and antifungal resistance was addressed with a possible role for combination therapies. So that's the highlight of the guidelines, and if you want to drop off to sleep at this moment, you can. But what I'm going to do now is go a little bit more in depth into the guidelines. So these were allegedly worldwide guidelines, but you can see that there are very large gaps, like most of South America is not represented, much of South America is not represented, most of Africa is not represented, certainly parts of Europe and Asia. And I find this map very hard to read, but I don't think Malaysia is actually on that map. I think it's probably Indonesia, maybe Sulawesi there, I'm not sure. But it looks to me as though Malaysia was not actually represented. There were 2 Australian representatives, Sharon Chen and Chin Neo. So they were the guidelines. So what they did was published a 227-page appendix to the guidelines. And I have gone through those 227 pages so that you don't have to look to see how they actually relate to the guidelines. So what I will be covering is just treatment of candidemia and deep-seated infection in adults. I do not have time to look at epidemiology, diagnostics, superficial infections, or pediatrics. But as has already been stated very nicely, tissues are all different from each other in their penetration of antifungal agents. This was a lovely table done by Tim Felton back in 2016, so 10 years ago now, and it's unfortunately never been updated. So maybe there's a nice project for someone. But as you can see, for ocular disease, the echinocandins have no role, as in the patient that was just presented, whereas 5-FC potentially does, as do the azole drugs. So you have to aim your antifungal drug for the infected tissue. So, for example, for a joint, you may choose an azole drug. There's not much data on the echinocandins. So it's really important to choose the drug according to the site of infection. There hasn't been a more recent review, as I said, but isavuconazole, if we add that to this chart, has excellent tissue penetration, including the epithelial lining fluid and the brain, whilst the newer echinocandins, such as rezafungin, the long-acting one which is coming along, have the same limitations as the parent drug. Okay, so, sorry, let's go back one slide, just skip through that. So page 74 of this mammoth appendix is pharmacokinetic considerations. They looked at fluconazole, other azoles, and echinocandins. So let's just very briefly look at what we know about pharmacokinetic considerations for anti-candida drugs. And this is from the DALI study from Jason Roberts' group that was published a few years ago now. And it was a large study of antimicrobials, but there was a small subgroup of antifungal drugs. And they had 15 patients on fluconazole, 9 on anidulafungin, and 6 on caspofungin, and obtained quite extensive pharmacokinetic data on these patients. And these are critically ill patients in intensive care. And when you compare the concentrations in the ICU patients with previously healthy volunteers or general patients, you can see that the concentrations in ICU patients and all the pharmacokinetic, pharmacodynamic parameters are around half that of normal healthy volunteers and probably close to half that of general patients as opposed to critically ill patients. So for fluconazole, caspofungin, and anidulafungin, this is a definite signal that we are not dosing appropriately in the intensive care setting. And the drug exposure is reduced by up to 50% in that setting. They look specifically at fluconazole, at the use of a standard one-size-fits-all 400 milligrams daily. And when that was converted to a milligram per kilogram dose, it frequently fell below the 6 milligrams per kilogram recommended dose, particularly as obesity grows within our populations. There's a recommended dose reduction of 50% in patients with a creatinine clearance of less than 50 mils per minute. But as fluconazole is reabsorbed by the renal tubules, you're not getting this reabsorption happening, so this dose reduction may in fact not be appropriate. And only 2 of the patients, both of whom had reduced creatinine clearance, received the recommended weight-based dosing, and both attained the target. And here you can see that if the dose were roughly 6 milligrams per kilogram, you were much more likely to attain the target than patients receiving a lower dose. So suboptimal dosing of fluconazole is very common. On top of that, fluconazole suffers from augmented renal clearance. Because it's primarily renally cleared, patients with risk factors for augmented renal clearance, such as critical illness, trauma, male, young age, and so forth, are at risk of subtherapeutic fluconazole concentrations. And unfortunately, we don't have a biomarker for augmented renal clearance. We simply have to assume that it is probably happening in anyone with a creatinine clearance of greater than 130 mils per minute. Okay, so what does page 74 of the appendix say about fluconazole? So the recommended dosing, the antifungal dosing should be individualized for the patient's age, weight, disease state, organ function, effective extracorporeal circuits if present, and infectious agents involved. For fluconazole, recommended dosing may result in subtherapeutic drug exposures in patients with obesity, sepsis-associated changes, changes in volume of distribution, high volume fluid resuscitation, augmented renal clearance, or renal replacement therapy, and that failure to administer a loading dose may result in delayed time to PK/PD target achievement, particularly in critically ill patients. So they recognise that fluconazole may need different dosing in these clinical settings, and they recognise the need for a loading dose. What happens when you look back at the actual guidelines? So on page 77, it again highlights the fact that fluconazole dose may need to be increased in specific settings, and that with a body mass index greater than 30, you may need to dose on a weight-based dosing rather than simply a standard dose. But if you look at the guidelines, nothing about a loading dose. It simply says 400 to 800 milligrams daily. And this is the 13-page published guidelines. So nothing at all about loading dose or weight-based dosing or increasing the dose in certain clinical settings. Second line and salvage therapy, exactly the same, 400 to 800 milligrams daily, and no mention of the need for loading dose. So this is definitely, I think, a problem with the guidelines for fluconazole dosing. What about the other triazoles? Well, it makes the point that they're used less frequently in the treatment of candidemia, but can be subject to clinically relevant pharmacokinetic variability, especially for voriconazole, for which TDM-guided dosing is strongly recommended. The volume of distribution and clearance of isavuconazole, posaconazole, and voriconazole are all altered at extremes of body weight, and in the setting of hypoalbuminemia, extracorporeal membrane oxygenation and renal replacement therapy. Okay, so once again, they recognise there's a problem. So voriconazole is dosed on a weight-based dosing, as is isavuconazole, and so they're dosed on isavuconazole is dosed on a standard induction and then daily maintenance dose. But poor old itraconazole, which is often used in resource-limited settings because it's much cheaper and generic, in fact, is no loading dose and only 200 to 400 milligrams daily, which in our experience would render most patients subtherapeutic. So the other azole drugs are not dosed appropriately either, and there is no mention of posaconazole, even though it is used in some clinical settings, and even though it's mentioned in the dialogue, it's not actually on the chart. Okay, so what about the echinocandins? There's a growing body of evidence that suggests that exposures with currently recommended doses for all three are lower and possibly insufficient in obese patients, in hypoalbuminemia, in critically ill patients, or in patients with elevated MICs near the breakpoint. And therefore, weight-based dosing may be more appropriate, particularly in critically ill patients. And there are multiple references in the appendix given to support this. And I've listed all these references here on this green chart. The two that are blacked out are not echinocandins. But for all of these, it's basically grade A recommendations that the dose should be increased. You can see up all these up arrows in a variety of specific clinical settings. The one where it's equivocal is a microfungan dosing, where it says perhaps if the patient is obese, you should increase the dose. So all of these suggest that in specific clinical settings, you need to change the dose of the echinocandins. What do we have here? Anidulafungin, standard loading dose and daily dose. Caspofungin, standard loading dose and daily dose. Microfungin, no loading dose, just 100 milligrams daily. So all of these may in fact be inappropriate in a number of clinical settings. You may in fact need a higher dose. So we've already heard a little bit about is 14 days the holy grail of treatment. So the recommended duration of candidemia without deep-seated or metastatic foci is 14 days from the first day of persistently negative blood cultures. And this comes from the appendix on page 101. And the original study, which this comes from, was the REX study. Some of us were actually involved in this many years ago, which was conventional amphotericin B versus fluconazole. So the echinocandins were not involved in that study. And that's the study that set the scene for 14 days treatment. There have been a couple more recent studies. The first one was to show no correlation between duration of therapy and delayed complications at weeks 3, 5, and 22. And in the second study, they looked at 5 to 11 days versus 12 to 24 days, but 90% received an echinocandin. And there was no difference, again, in deep-seated infection or relapse in the two different groups. So perhaps we don't need 14 days in the era of echinocandin therapy. And this was a very nice review in The Lancet very recently, which looked at towards shorter therapy for candidemia, how to define the patients who are uncomplicated, the low-risk patients in whom you could potentially stop treatment after, say, 7 days and not continue for the 14 days. And I won't go through it all here, but basically they're patients who are uncomplicated, they're not neutropenic, they don't have a malignancy, and you can get the lines out and they don't have deep-seated infections. So it's well worth looking at this paper and thinking, can we potentially reduce the duration of our Candida therapy in some patients? But as the authors say, ultimately only a double-blind randomized controlled trial will actually ever provide evidence as to whether patients with uncomplicated candidemia are currently overtreated. Catheter removal. The guidelines strongly recommend central venous catheter removal as early as possible when the catheter can be safely removed. However, there have been no prospective clinical trials designed to evaluate catheter removal. Sorry, I just have a sip of water. In candidemia and the impact on outcomes, including mortality, clinical response, or persistence of candidemia. And in a Cochrane meta-analysis, 73 observational studies were reviewed. 40 studies reported a beneficial effect of catheter removal, but 33 showed no difference between the groups. And there were no firm conclusions possible as the populations and interventions were extremely heterogeneous. So maybe catheter removal doesn't have to be done. What about CNS infection? We've just heard a little bit about this from Dr. Aisha. So regarding echinocandins, their poor CNS penetration limits their use. When I look at this page in the guidelines, in fact, it says any echinocandins. Now, you wouldn't want to be colorblind because when I first read this, I thought they were actually marginally recommended. But if you look at the color coding, it is subtly different for marginally recommended versus recommended against. And I think that's very easy to make a mistake if you just simply quickly look at the guidelines and think, oh, that's okay, we can actually use any. So what about fluconazole? For some reason, it's suddenly fluconazole 800 twice a day with or without flucytosine 150 milligrams a day. So they've doubled the dose, but still no loading dose. And for salvage treatment, they say fluconazole 400 to 800 a day with or without flucytosine. However, they obviously realise there's an error in this because the authors, sorry, I'll come to that in a sec. Caspofungin, again, standard dosing, and that's given as salvage treatment, even though the echinocandins don't penetrate well. And they talk about intrathecal caspofungin or amphotericin, but there's minimal discussion and only 2 references cited in the actual appendix. So whilst they're recommended, there's very little data to support it. So as I was saying, they realised that there was an error and the fluconazole dose should be 800 milligrams daily, but again, no mention of a loading dose, so it's going to take much longer to get to steady state. And the flucytosine should be given 4 times a day, not as a single daily dose, so that they recognise the error in this. What about ocular candidiasis? We've heard about this now. So basically, there's not a lot of data and that ID should collaborate with ophthalmologists. But if you look at this, it says fluconazole 200 milligrams daily or twice daily, which seems to be a homeopathic dose for something that's actually a sanctuary site of infection. And if you look at the actual page 111 in the appendix, it says that intravitreal fluconazole with parenteral therapy is given for 4 weeks, and then fluconazole 600 milligrams daily for 20 weeks. So they've put the dose of fluconazole of 200 milligrams a day, but not mentioned the intravitreal therapy that is actually meant to accompany it. So again, another error in the guidelines. There's no mention of intraocular voriconazole or fluconazole, and both of these things are fairly commonly done by the ophthalmologists at our hospitals, so no mention at all of their use. What about Candida endocarditis? So the first thing is surgery, valve replacement and or removal of the implanted device. But when you actually go to the data in the appendix, there is actually very little benefit shown to surgery. So in these major studies, all of which are classed as B degrees of evidence, the biggest ones show mortality is not impacted by surgery and there's no significant benefit. There are individual case reports which show that there may be a better outcome in some smaller studies, but the surgery is definitely not clearly indicated in every patient. High-dose caspofungin, 70 to 150 milligrams daily. Micafungin, 150 milligrams daily with or without fluconazole. Anidulafungin, 200 daily, then 100. And then caspofungin, 70, then 50. So what we have here is an increased dose, but no loading dose in these two. So they've increased the dose, but not given a loading dose. And in these two recommendations, it's standard dosing with a loading dose. So again, the recommendations for dosing are really not in keeping with what should actually be happening in the patient. And for fluconazole as maintenance therapy, again, we're back to 400 milligrams once or twice a day with no weight-based dosing at all. What about TDM, the Holy Grail? Well, basically, access to TDM is very variable, and wherever you have it, it should be used because most patients are highly complicated and require therapeutic drug monitoring. And I know that it's growing and expanding significantly in Malaysia, which is fantastic. And hopefully you'll have access to some more of the antifungal drugs in the not too distant future. They talked about Bayesian modelling in the discussion, but there was nothing about it in the recommendations. And the advantage is that you don't have to have a trough concentration. You can have a midpoint, and with modelling can work out the appropriate dose. So it takes the need for a trough concentration out of it. Now, look, I won't talk about biofilms because we're running short of time, but it has been mentioned by Dr. Aisha. But just to say that biofilm-producing Candida is associated with an increased mortality. So this is non-biofilm producing strains versus biofilm producing strains, and there was a very significant increase in mortality. And the reason we worry about biofilms is that the azole drugs and conventional amphotericin are inactive in biofilms. So the MIC for voriconazole, which may range between 0.3 and 8, 0.03 and 8, rises to untreatable, 128 to greater than 256 in a biofilm, and same with fluconazole. So if you have a setting where you cannot debride a biofilm, then you should not be using an azole drug. The role of fundoscopy I'll talk about very briefly because the patient had fundoscopic examination. So originally it was recommended for all patients. Then the American Academy of Ophthalmology expressed concern that it may lead to unnecessary and harmful treatments. There have been no trials on ocular screening guided management and no cost-benefit data. And the evidence neither supports nor disproves the benefit of routine screening or specific treatment regimens for chorioretinitis. So the arguments against routine screening are that in some studies, it has a low incidence. There's a lack of conclusive outcome benefits, difficulty in obtaining in-house ophthalmology at many hospitals, and potential for harm if the fundoscopic findings lead to longer systemic therapy, intravitreal therapy, or vitrectomies. The counter-argument is that detection and extended treatment of chorioretinitis may be effective at preventing endophthalmitis. Ocular candidiasis can also be a marker for deep-seated candidiasis. However, targeted strategies will miss 33% of patients with ocular candidiasis who do not have visual symptoms and 60% of those who are unable to report visual symptoms because they're unconscious in ICU. So just to finish up, you can lead a horse to water. So do guidelines make a difference? This is a study from Brazil, over 11 tertiary hospitals, 314 ICU patients with candidemia. There was no change in mortality over the period of introduction of the guidelines. Candida albicans remained their most common isolate, followed by Tropica and Glabrata. The use of echinocandins increased significantly in the second guideline period, but 70% still did not receive these agents as first line. In this study, they found that catheter removal was only done in about half the patients, but it was associated with an improved 30-day survival. So their findings underscore persistent gaps in adherence to guidelines, particularly regarding timely echinocandin initiation and catheter removal, strengthening therapeutic strategies focused on these key interventions. This is not a study of yeast. It's actually a study looking at voriconazole dosing from Japan. And as we know, the Japanese are usually very, very good at mandating treatment regimens and TDM. They had 2,197 patients, and even though they had multiple pharmacists involved, the implementation rate of a loading dose remained below 65%. So even though you have pharmacists involved and excellent guidelines, it doesn't mean that they will be followed. This was the study from Olivier Lothellari I mentioned earlier, and his take-home message was neither the availability of new antifungals nor the publication of numerous guidelines prevented an increase in Candida albicans, candidemia, and death in ICU patients between 2002 and 2010 in Paris. Another study which looked more recently at guidelines showed that if you did adhere to the guidelines, there was actually an increased survival, and you can see that the adherence to things like ophthalmology and echocardiography were very low in the white, whereas adherence to starting with an echinocandin and 14 days of treatment was better. So they did find an improvement in mortality. And of course, just a couple of weeks ago, something was published looking at the impact of Candida Care Bundle on compliance on the prognosis of patients with candidemia. So this is a large study from 9 Japanese hospitals. They based their Candida Care Bundle on 5 of the important things: catheter removal, appropriate antifungal therapy, ocular examination, follow-up blood cultures, and antifungal treatment for 2 or more weeks after clearance. And they looked at high and low compliance. And the bottom line was that there was significantly lower 30-day mortality in the high compliance group, 8.8% versus 57.1%. Candida albicans and central line-associated infections were associated with fatal outcomes. Endophthalmitis occurred in close to a quarter of the patients and was associated with Candida albicans and central line-associated infections. So, candidemia treatment guidelines, the good and the bad. So the good is they provide a standard of care. They are evidence-based. They have reduced variability in clinical practice. They emphasize source control, and they specify, although it may not be correct, a duration of therapy. The bad is the evidence gaps. There's often low quality of evidence, limited adaptability between settings. Local epidemiology is not always covered. Cost and resource availability, and adherence is often poor, but does it matter? Some studies suggest it does, some suggest it doesn't. But probably the most important thing is the ugly. You have to read and understand that 227-page appendix when relying on any sections of the guidelines, because things may not be quite as they seem. The devil is in the detail. Thank you very much, and I'm very happy to take any questions in a panel discussion. Thank you.
Thank you very much, Prof. Marriott. Thank you for making a conclusion of the 227 pages of the appendix guideline. So I have questions in the question and answer column. So the first one will be for Prof. Marriott. In resource-limited setting, in which in Malaysia, Candida albicans is still the predominant species with more than 80% sensitivity to azole. So can fluconazole be used instead of echinocandin? What's your take on this?
That's a really difficult question. I think a lot of the problems with the The early study was the Riboli study, which looked at fluconazole versus anidulafungin. And it was from that study that we got the data that suggests that the echinocandins are associated with a better outcome. But that study was done in Americans, and that study was done at a standard dose of 400 milligrams a day of fluconazole with dose reduction in renal failure. So I suspect none of those patients were actually dosed appropriately, because obesity in America means that 400 milligrams is not going to be an appropriate dose for most patients. So whilst the guidelines say that you should be using an echinocandin, and in a setting where there's a biofilm likely, yes, you probably should. But I think appropriately dosed fluconazole really should be studied again, because if we do milligram per kilogram dosing and we do give a loading dose and we do hopefully do some therapeutic drug monitoring, it may in fact be as effective in resource poor settings. I just think the studies were done inappropriately early on, and we just don't have the answers as to the echinocandins necessarily being superior in all clinical settings. But there is a huge cost difference, I know.
Okay, the second question, probably for Dr. Aisha. The risk of catheter-related infection is higher if new catheter reinserted within 3 days at the same or different site from the previous. Can I have Dr. Aisha?
So I think the question is based on what I talked about. So that was only from that one paper which examined that timing of reinsertion. So I guess the answer can be quite controversial and difficult to answer, because from that one paper it's found that the risk of reinfection is higher if it's lesser than 3 days. But it didn't actually mention whether it was recited into the same place or in another place. So I guess it goes back to your clinical judgment and as well as your patient needs and indication, because catheter insertion is not a simple procedure to be done to anyone. For Marriott, what would be your opinion on this?
I missed the first part of the question. It was very soft. Sorry, what was it?
The risk of the catheter-related infection is higher if a new catheter reinserted within 3 days at the same or different site from the previous. Just now, Dr. Aisha's presentation was saying that one of the risks is catheter reinsertion. So within 3 days. So if the catheter is reinserted on another site, will the risk be the same?
So if the candida is isolated from blood originally and then from another site, is that the question?
I think the question is referring to the catheter-related candida infection.
Catheter related, right. So removal of the catheter, we don't know. It's probably should be done, and some studies say it should be done. Some are more equivocal. There's never been a randomized study, I don't think, to say that the catheter should be removed, but it makes sense intuitively where you can remove the catheter to actually do so. So if the catheter is removed and the patient remains fungemic, then I would actually strongly consider an echocardiogram to make sure they don't have endocarditis, or some other hidden focus. So if the patient remains fungemic after that catheter has come out and hasn't settled within, say, 72 hours, then I think they need to have further investigations to see whether or not they have endocarditis, whether they have a deep focus elsewhere, such as the kidneys, whatever.
Okay. Prof, you can look at there is a Q&A column that only the panelists can see. Maybe you can have a look at the question as well, but I will read it out in case if you cannot hear me that well. Okay, question number 3. Dear Prof. Deborah and Dr. Aisha, any difference in choice of echinocandins available? Any situation that one echinocandin is more suitable than another? Thank you. So the choice of echinocandin, can we choose any one of it, or is there one that is more suitable than another?
They're not quite all the same. They're very similar, but they're not quite the same. There's some suggestion from some studies that micafungin may have better biofilm activity than the other two drugs, than anidulafungin and caspofungin. So if you're dealing with a biofilm situation, then that might be something to consider. The other thing is that caspofungin has a degree of drug interactions. It's a weak inhibitor of cytochrome P450 enzymes. So if you want a totally clean drug with no drug interactions, then you would choose anidulafungin or micafungin and not caspofungin. Overall, they're very similar, subtle differences.
Next question. When should the second dose of fluconazole be given following the loading dose?
So it depends whether you're giving daily or twice daily dosing. So we would normally load at 12 milligrams per kilogram on the first day, and then 6 milligrams per kilogram thereafter. And if the patient is on renal replacement therapy, you may need to actually continue at that higher dose of 12 milligrams per kilogram. So day one is loading, and it can be given all at once or split as twice daily. We tend to give it once a day because it has a long half-life. So we tend to use once daily dosing of 12 milligrams per kilogram, followed by 6.
All right. Hi, Prof. Deborah and Dr. Aisha. For Candida IE, awaiting for surgical intervention, which antifungal regime preferred? Is it M4B or echinocandin? Or does it need for high dose versus M4B and flucytosine? Thank you. I think you've answered this. There is a guideline on that previously, right?
Sorry, for which site was that? Which waiting surgery for which site?
Infective endocarditis.
Right. Yeah, so the guidelines, as I said, are really not all that helpful for endocarditis, but dose appropriately. And probably an echinocandin in that setting if it's cost effective, because there will be a biofilm on that heart valve while awaiting surgery. So until you get source control in that setting, I would use an echinocandin and then potentially swap to fluconazole once the surgery has been undertaken and the source is controlled and the biofilm has hopefully gone.
Okay. Candiduria due to Candida glabrata.
Nah, that's a difficult one. I'll be interested to hear what Dr. Aisha does too. It's a very difficult one because the echinocandins don't penetrate well into the urine. They do get into the kidney, but they don't penetrate well into the urine. There has been a study which showed that patients with renal disease, with Candida or Nacosomyces glabratus, those patients actually do just as well on an echinocandin, but it was a fairly select group of patients. I think from memory, it was a few years old. I think they had renal abscesses and candiduria from that. So what we would do is normally, if the organism has a reasonable fluconazole MIC, so say 2 to 4, even up to 8, we'll actually treat with high-dose fluconazole because we know that gets into the urine in very high concentrations. If someone has a renal abscess, that's a little bit more difficult. You might need to go to an echinocandin in that setting. But for candiduria, high-dose fluconazole, assuming it's not completely resistant, would be our choice. Dr. Aisha, what would you do?
Actually, I've not had much experience with candiduria, but we tend to fall back to sometimes amphotericin B because of the availability in some settings. But I suppose because of the better safety profile of echinocandins, it would be better to consider echinocandins rather than M4B.
What about to Dr. Deborah? Have you dosed morbidly obese patient more than 100 milligram OD, like 150 milligram OD, or what's the dosing?
What drug are we talking about? Sorry.
Hold on. Actually, it doesn't mention. I think we'll be talking about the azo.
If it's fluconazole, then I have dosed a patient with resistant cryptococcal meningitis in the early days of HIV with 1,600 milligrams a day for 3 years. And that patient is still alive, went back to work. He managed to survive until antiretrovirals came through, and he's still working as an architect. And he had 1,600 milligrams a day for 3 years. I think people are afraid of fluconazole because it came after amphotericin and people were afraid of amphotericin. But we rarely see side effects from fluconazole. And we're very happy to dose 1200 milligrams a day. Very happy to. Just watch the liver function test, but often that you can treat through that as well. But following immediately from amphotericin B, I think people were scared of antifungal drugs and scared to increase the dose. And I think, therefore, it's often actually been underdosed to its detriment.
What about case of prosthetic joint infection with Candida, which is resistant to fluconazole, sensitive to echinocandin, but as you mentioned, not a good choice?
I would be asking what the MIC is for voriconazole, because voriconazole does have good penetration into joints and joint fluid. But the problem is, unless you debride it, you've got that biofilm in there and it's not actually going to be effective. So it's a difficult one. If the voriconazole MIC is low enough, and we actually have a patient at the moment with a Nakasaomyces glabratus in a knee joint. And in fact, we're treating him with voriconazole. The MIC is lowish. And so we're actually able to treat with voriconazole, and he's gone to theatre and had it washed out and debrided. So if you can get rid of the biofilm, then voriconazole may be a reasonable alternative. If you can't, then it's really difficult because the echinocandins don't penetrate all that well.
Okay. Any preference for Candida glabrata, i.e. infective endocarditis? Maybe combined fluco and mica fungin versus M4B? Any role of oral voriconazole later, but it doesn't have breakpoint?
Right. Well, again, it would depend on the susceptibilities, I think. Yes. Yeah. Liposomal amphotericin B has good biofilm activity. So if you have to leave the valve in, if the patient doesn't have surgery, you could not use conventional amphotericin because the biofilm activity is poor. But you could use liposomal amphotericin, which of course comes at a very significant cost, or you could use an echinocandin, assuming that it is actually susceptible, and which it should be, being a Nakasaomyces glabratus.
All right. What is the recommendation for, maybe you've answered this one. Is there a maximum capped dose of fluconazole? Can we go beyond 800 milligram per day to achieve the 6 milligram per kilogram?
Absolutely. Absolutely. Yeah. As I said, we treated a patient for 3 years at 1,600 milligrams a day. Not something we would normally do, but we didn't have antiretrovirals in that era, and he had resistant cryptococcal infection. But certainly 1,200 milligrams a day, we're quite comfortable going to.
Yeah. What is your recommendation for Candida glabrata candiduria with renal abscess, in which blood fungal culture no growth? Would you prefer fluco or echinocandin, since there is no recommendation for voriconazole?
If the blood cultures are negative, it's simply a candiduria.
Yeah.
I would look at the
Yes,
MICs.
simple
Do you have
candid-
access to the MICs for urine isolates?
Yes, we should.
Yeah.
Actually, no. We don't really do. We don't really proceed MICs for non-sterile sample. However, in special cases, the clinician can talk to us and we can do that. Basically, only for special cases lah, if we were asked to.
Right.
So the answer is yes.
Yeah, so
Okay.
if you can get an MIC and it's relatively susceptible and the patient is not candidemic, then I would potentially go with fluconazole in that setting. If the patient is candidemic, that's a different story. I think you may even need to consider combination therapy with an azole and an echinocandin.
All right. What's your opinion about increased fluconazole dose 50% more, for example, 1.5 times more, when the patient is on CVVHD, as suggested by certain drug reference, considering the renal reabsorption is impaired?
So if the patient is on CVVHD, the recommendation is 12 milligrams per kilo per day. So the recommendation is that, depending on the type of filtration, but the highly effective ones will take the fluconazole off, so you need the 12 milligrams per kilo per day. So in CVVHD, then high dosing.
Okay. How does one stop preemptive antifungal in ICU with a positive Manan or PCR in ICU, low for PPV. So do we continue while they remain in ICU? Should we repeat and stop if negative?
It depends on the clinical setting. Galactomannan in what setting? In bronch, in blood?
Mm.
It just depends on the clinical setting. We actually don't measure beta-D-glucan or any of the Candida laboratory measurements because they're extremely expensive and not all that helpful always. But it would really depend on the clinical setting whether you continue once they leave or not. Dr. Aisha, you might want to comment on that one too.
Yes.
Well, Mary, I was just wondering about that question. So, in the setting of high-risk patients, would you consider repeating your biochemical, the beta-glucan test or fungal PCR if you were not happy with the first test?
It depends again on the site. Were we talking blood or bronchoscopy?
So usually it will be a bronch sample.
Yeah. So bronchoscopy, it would really depend on the the likelihood of underlying infection, the degree of positivity of the galactomannan. So if the galactomannan is borderline, and you maybe get one colony of aspergillus growing, which may or may not be significant, we would often just wait and watch with that sort of patient, particularly if they're at low risk of invasive aspergillosis. If it's a hematology patient, they're probably more likely to get antifungal therapy. But if it's a sort of standard respiratory patient who's had a bronchoscopy, they've done a galactomannan, it's weakly positive, but either not much growth or no growth, then we would probably wait and watch in that setting. Hard to repeat a bronchoscopy, but it would be done if necessary.
Right.
If they're intubated, it's much easier. You can just get an endotracheal aspirate.
Sure.
Okay. For a prostatic joint infection with Candida albicans, will there be a benefit to combine micafungin for the biofilm and azole for joint penetration? And is there evidence to support oral option? And when can we do that if patient is clinically well?
Absolutely. So the azole drugs all have pretty good bioavailability. So an oral option, if the patient is well, is perfectly reasonable and strongly encouraged where possible because it means you get a line out, you don't have the risk of line infections and things. So yes, an oral option is absolutely fine, particularly if you have access to therapeutic drug monitoring. So I've not seen a lot of studies that have actually looked at combination therapy in joints. Dr. Aisha, I'm not sure whether you have. Theoretically, it makes sense because of the activity of the biofilm, but the echinocandin has to get into the joint first to be active in the biofilm. So if the activity is, if it's difficult to get into the joint, you're wasting your money basically. So you might be better off dosing with a high dose of an azole drug and getting source control.
Okay.
But certainly oral, yes, definitely. Strongly support oral. Our AMS pharmacist is a devotee of oral therapy. Wherever possible, change to oral agents.
Okay. There is a risk of since there is a risk of biofilm if catheter is reinserted within 3 days while waiting, should the antifungal be given only peripherally?
That was Dr. Aisha's patient, so we'll hand that one to you.
I think the question is, should you treat the candidemia, right? So if there is candidemia, then you should continue to initiate your antifungal therapy. I don't get the question about being given peripherally, because that is how we would administer our antifungal.
So I think the question was about reinserting a new central line, wasn't it? And I think ideally that shouldn't be done if possible, that you probably should try and clear the fungemia first and allow the biofilm to dissipate and then put in a central line when necessary down the track if necessary, or change to oral therapy if that's possible.
Okay. Hi, Prof. For Candida infective endocarditis which does not fit for valve replacement, will you consider lifelong ESO? For how long? 1 year or really lifelong?
I've actually got a patient in whom I'm agonizing over this myself. She actually had Candida parasilosis, fit, healthy young girl, Candida parasilosis endocarditis, not a drug user. Had all of that removed, had a new valve put in, put her on suppressive therapy, stopped it at 12 months, and within 3 months she'd relapsed, so needed a Bentel's procedure. Again, the same organism, Candida parasilosis, and she basically is on lifelong suppressive therapy now. I think every time I see her, I think, should we stop it? But then I think she's had 2 lots of surgery, a Bentel's procedure. You just can't afford to. So she's actually on suppressive fluconazole. She was put on voriconazole at one stage by another consultant, but had terrible photosensitivity. And so she's on lifelong suppressive fluconazole and happy to take it. So the answer is yes. And particularly in elderly patients, if you don't want to operate, I would put them on lifelong suppressive therapy. We just actually had a patient not that long ago who had a Candida albicans in a hip, post total hip replacement, an 88-year-old. The wife of an anaesthetist is always the partner of a medical person that this happens to. So she was the wife of an anaesthetist, and she was treated for a year with fluconazole. The fluconazole was stopped, and within 6 weeks she relapsed. So she's now on, she had it washed out and she's on lifelong therapy. So I think the answer is yes. When in doubt, look at lifelong suppression.
Okay. Hi, Prof. When you use the ultra dose of 1,600 milligram of fluconazole, were you guided by TDM? As we don't have TDM here in Malaysia.
Yeah, look, we actually developed TDM around that time, and not for fluconazole initially, though. Initially, it was voriconazole and fluconazole. Actually, yeah, it was. From memory, and it's a very long time ago now, it would have been 1992 or so. I think the TDM probably came along just after that patient. So I was just guided by his liver function tests and how he tolerated it. And he tolerated it very well. His isolate was amphotericin B resistant, which was unusual, but it was. So we had no options. We had no voriconazole in those days, which often has lower MICs for Cryptococcus. So we've used voriconazole quite frequently as salvage therapy for Cryptococcus, but we didn't have it in those days. So we were reliant on the fluconazole. So I think from memory, it wasn't TDM. I think it was him and his liver function tests.
All right. Um, Unfortunately, due to the timing, I will read one last question. And well, the question, maybe email our using our email, and then we'll get Prof to answer them via email. Is that okay with you, Prof?
Absolutely. I'll try and be good and get to answer them. I promise I'll try my hardest.
Okay. Okay, the last one. Candida auris seems to be emerging in Malaysia. What choice of antifungal for Candida auris while sensitivity is still pending?
So for Candida auris, we would recommend an echinocandin. We now actually screen all of our patients who've come from overseas hospitals and have picked up Candida auris in several, mainly from Africa and India, not from Malaysia so far. But we would recommend an echinocandin, but just beware that some species of auris are actually resistant to echinocandins. They're pan-resistant to the currently available antifungal drugs. So we would start with an echinocandin and then modify as necessary once we got the susceptibilities through. Actually, Candida auris is very interesting because it doesn't actually form a strong biofilm. But what it does do is it forms a specific biofilm on skin. So it has a particular predilection for skin. And that's one of the reasons why it spreads within our hospital system, because it actually colonizes skin. So unlike other candidas, which may colonize the gut, the genital tract or whatever, auris actually has a biofilm and colonizes skin. And so that's the reason why it's such an important pathogen in hospitals for nosocomial spread.
Okay. Thank you so much, Prof. And thank you, Dr. Aisha, for the lovely education to us. So for everyone else, please fill in the attendance form. And also, if there's any more question, and also I'm very sorry, we are very sorry that we have to cut this at this time because Prof has to be somewhere, and So yeah, we will answer the rest of the questions via email. We will email you, Prof, and take your time. There's no need to rush. And also for everyone else, it seems that there's a lot of questions on IE. Actually, on the 25th of March, we have another webinar, which we will collaborate with EFISG. So we will be talking about infective endocarditis then. So hopefully stay tuned for the announcement.
And don't forget the Asia Fungal Working Group, which is in Kuala Lumpur, September the 9th to the 11th of this year.
Yes, correct.
Yes, so hopefully I'll be able to get across for that.
Hopefully we will see you then, Rob.
I hope so. Thank you very much for the invitation, and hopefully I'll see you all in person very soon. Sampai jumpa lagi.
Thank you.
Prof.
Bye-bye.
Thank you, Dr. Aisha.